The maxillary, or second division nerve block, will anesthetize the entire hemimaxilla with a single injection. The target of the injection is the maxillary nerve as it passes through the pterygopalatine fossa.
3 approaches to the maxillary nerve block are possible. The high tuberosity approach is the easiest to perform technically and the least likely to cause discomfort, but is the most likely to cause a clinically evident hematoma. The pterygopalatine canal approach ensures accurate placement of the needle, provided it can be successfully inserted up the canal. This injection also requires a separate palatal infiltration to minimize discomfort. The extraoral approach, in which the pterygopalatine fossa is accessed percutaneously, requires disinfection of the skin, is rarely used, and will not be demonstrated. The high tuberosity approach is almost identical to the posterior superior alveolar nerve block, except that the needle is inserted much deeper and slightly more medially to enter the pterygopalatine fossa via the pterygomaxillary fissure. Insertion is at the height of the mucobuccal fold, just behind the zygomatic process, in an upward, inward, and backward direction. With proper orientation, the needle tip will come to rest at or within the pterygopalatine fossa, slightly lateral to and about 1 centimeter below the maxillary nerve. Clinically, the 25-gauge long needle used for the injection can be bent 30 degrees at the hub to facilitate medial insertion. Because this action weakens the needle, the patient must be cautioned to remain still during injection, and the needle must be advanced gently through tissue. The 11 o'clock position may be used for both the right and left high tuberosity block. The patient's neck is extended and the head turned to permit visualization of the buccal vestibule. A finger is used to palpate the zygomatic process. The mouth is partially closed and the jaw is shifted toward the site of injection. With the palpating finger placed over the zygomatic buttress, the needle is carefully moved into position. The needle tip is inserted in the height of the vestibule as previously described, and slowly advanced superiorly, medially, and posteriorly along a straight path to a depth of 30 millimeters for the average adult. After a negative aspiration, the entire contents of the 1.8 milliliter cartridge is slowly injected. Premature contact of bone requires that the needle be withdrawn before being reoriented to minimize the chances of hematoma formation. A positive stop against bone near the final depth of insertion probably means that the needle has impinged on the pterygoid plate. In this case, the needle should be withdrawn slightly, a negative aspiration obtained, and the anesthetic solution injected. Anesthesia will often be obtained because of medial spread of the solution. If it is not, re-injection along a slightly more medial pathway can then be performed.